Today we are focusing on management of bipolar affective disorder. So, firstly, focusing on management of bipolar affective disorder. There is maintenance therapy between episodes. In episode, there is acute management. Acute episode mania risk assessment is done by harm to self or others and neglect. Treatment setting mainly depending on the risk state, usually inpatient, outpatient if there is good support system. De-escalation by verbal or pharmacological done. General advice as we give: avoid excessive stimulation, delay important decision, establish a structured routine, regular sleep pattern, level of activities reduce. Consideration in pharmacological treatment: severity of symptoms, current medication, previous response to treatment. In pharmacological treatment, patient on antidepressant, we have to stop the antidepressant. Patient not on antimanic treatment, start on the following: antipsychotic, mood stabilizers, lithium sodium valproate. Example: antipsychotic, olanzapine, risperidone, quetiapine. If no response to antipsychotic, augment with lithium sodium valproate and lithium. Indication: previous response to this medication, shown good compliance to oral medication, inadequate response to antipsychotic. Both valproate and lithium high risk for fetal abnormalities, better avoid in women of childbearing potential. Lithium has slow onset of action than antipsychotic and valproate. Side effects of lithium: polyuria, polydipsia, dry mouth, fine tremors, metallic taste in mouth, mild gastrointestinal upset, acne, and psoriasis can be aggravated. Ankle edema, weight gain, nephrogenic diabetes insipidus, usually short-term and reversible. Rarely intestinal nephritis and renal toxicity. Hypothyroidism with long-term use, hyperparathyroidism, hiathine. Because of lithium, they intend to drink more water in patients with lithium. Weight gain can occur, so advise controlled diet. Lithium toxicity level more than 1.2 millimole per liter is considered as toxic symptoms. JFS as increasing anorexia, nausea, diarrhea. CN effects: muscle weakness, drowsiness, ataxia, cause tremors, muscle twitching, dystonia, hyperreflexia. At level more than 2 millimole per liter, increased disorientation and seizures may lead to coma and death. Management: isosonic sodium chloride to enhance GFR and clears lithium. Lithium is water soluble, has low volume distribution, and lack protein brine. Protect airway due to risk of aspiration. Hemodialysis: protect airway to risk of aspiration. So hemodialysis, also in hemodialysis and peritoneal dialysis in patient with renal failure, and in instance where patient cannot tolerate high volume. CCF, liver disease in severe nephrotoxicity. In stages we give benzodiazepine, phenobarbital, or propofol. Measuring lithium level: blood should be drawn to 12 hours. 1 or -1 hour after the night dose before the morning dose. No fasting required. In exam question, how to get a blood sample who is in lithium, this can be asked. Other antiepileptics as mood stabilizers, carbamazepine not routinely used in acute mania. Lamotrigine has evidence for bipolar depression. Gabapentin is not recommended. Topiramate we use as an antiepileptic as mood stabilizers. Pharmacological treatment. Patient on treatment experience a manic episode, antipsychotic, check compliance, dose interaction. So let's we see a picture of bipolar affective disorder. Patient on treatment experience a manic psychotic, antipsychotic. So check compliance for dose interaction increase as necessary. If no improvement, add lithium valproate. On patient on lithium or valproate on suboptimal dose, increase dose lithium level around 1 milliequivalent per liter. Inadequate response, augment with an antipsychotic. Pharmacological treatment, initial management of acute behavioral disturbance or agitation. Short-term use of a benzodiazepine should be considered. Bipolar depression. Bipolar depression, antidepressant never be to be used as monotherapy. SSRI preferred over other antidepressant. Disadvantage of antidepressant. Risk of manic switch. Mood stabilization, rapid cycling. Mood destabilization, rapid cycling. Apparent low efficacy than unipolar depression. Bipolar depression. Lithium alone is ineffective in significant proportion combined with antidepressant. Lamotrigine free of manic switch and rapid cycling. Quetiapine, olanzapine plus fluoxetine can be given. Electroconvulsive therapy indication and contraindication. Electroconvulsive therapy considered when adequate trial of drug treatment is inadequate. Potentially life-threatening, severe depressive illness, catatonia, prolonged or severe manic episode. Maintenance treatment, long-term treatment like pharmacological, psychological, and social. Pharmacological choice of drug, lithium, olanzapine, or valproate, responsive to previous treatment. The relative risk and non-precipitant of manic versus depressive episode, physical risk factor, patient's preference. Acute management continues until the patient has been asymptomatic for at least 8 weeks. Then, depending on clinical symptoms, medication can be gradually reduced to reach the maintenance treatment. If adequate lithium dose is decided by the blood level, adequate lithium dose is divided by the blood level. In acute mania, lithium level is maintained in upper range. In maintenance therapy, level is maintained between 0.6 to 0.9 milliequivalent per liter. If decided to withdraw lithium, it has to be done gradually. 100 milligram per week. Rebound mania with sudden withdrawal can be occur. After acute depressive episode, following successful treatment on acute depressive episode, antidepressant should not be routinely continued long term. No evidence has reduced relapse rate. May be associated with increased risk of switching to mania. Tail of antidepressant, maintain antimanic drug maintenance therapy. Duration of treatment, long-term drug treatment continued for at least 2 years after first episode of bipolar disorder. If there are no relapses during this 2 years period, Two or more episodes within 5 years. Long term treatment may be lifelong. Psychotic management, general advice, sleep hygiene and regular lifestyle, avoid triggers of relapse, early subject to signs of relapse, relapse signatures and plan for action, treatment compliance should be maintained, general coping strategies, support during life events, avoid substances, proper dietary habits. So we reached the end of this part. So thank you for listening.